Hey folks, Ryan here and welcome back to the Reading Room, where I'm going to share actionable tips and tricks that you can use to level up your radiographic interpretation in veterinary practice. This week we're talking about linear foreign bodies. I want to make it so that you can diagnose a linear foreign body in a dog with confidence every single time. So let's jump in. A linear foreign body is typically caused by a cloth or a string. And these foreign objects that our patients, our dogs ingest, are anchored either in the stomach or underneath the tongue in the most common areas. What ends up happening is, as these pass from the stomach into the small intestine, they cause plication or bunching of the intestines along the length of the foreign body. And these foreign bodies require surgery. There are certainly some types of foreign bodies, maybe nonlinear intestinal foreign bodies or gastric foreign bodies, that we can get away with non-surgical interventions, maybe emesis in the case of a gastric foreign body, or sometimes we can wait for intestinal foreign bodies to pass. But when it is a linear foreign body, it becomes a surgical disease. One important thing to note is that when we talk about linear foreign bodies, we're not talking about linear objects like sticks. It's pretty common for dogs to ingest sticks and things like that, but that's not classically what we mean when we say linear foreign body. We're specifically talking about the disease process where there is an anchor point and plication of the intestinal tract. When we think about linear foreign bodies and we look to the literature, there's a really nice review in the Journal of Small Animal Practice, JSAP, which looks at linear versus nonlinear gastrointestinal foreign bodies. And this series had almost 500 dogs that they looked at. What they found was that the common clinical signs in patients with linear foreign bodies are vomiting, anorexia, lethargy, and pain on abdominal palpation. For all of these patients, they proceeded to surgery for treatment. There is a risk of necrosis, perforation, and often requires resection and anastomosis at the time of surgery. They found in their population of patients that there was an increased cost of hospitalization associated with these because of the types of surgeries being performed. But what they did find, and importantly for our clients and for our patients, is that there is a similar survival to nonlinear foreign bodies. So even though these are more significant interventions, the survival rate in these patients was similar, which is great news for our patients. So how are we going to go about diagnosing these linear foreign bodies? Well, I have 4 tips for you to think about. The first is that you always need to have a left lateral projection of the abdomen. This is going to help you look for an anchor spot in the pyloric antrum. Finding that foreign material there, and especially seeing it anchored, which we'll take a look at a couple examples of, is going to help tip you off to a linear foreign body. The second is looking for atypical gas shapes. So comma-shaped gas opacities, or some people will refer to them as geometric gas opacities. These are unusual, maybe angular margins that we don't normally see with rounded gas opacities in the intestine that are common. We will oftentimes then see plication and medial displacement of the duodenum, sometimes both in conjunction. So let's look at a few cases and see how we can identify this. We're going to start with a non-linear foreign body. So this dog ate a sock. It's a silly beast, but for whatever reason they love those socks. And this one ate a sock which is located in the mid-jejunum. What I'm noticing in this ventrodorsal projection on our left and right above me here, this left lateral projection, is that the pyloric antrum is filled with gas. This is the normal distribution of gas in the left lateral projection, and we can really nicely see here this duodenum extending in its normal location along the length of this patient. And again, in the ventrodorsal projection, we've got a pyloric antrum filled with gas and a nice straight shot of the duodenum down the right body wall here. That's our normal finding. Over here we have our intestinal foreign body. There's this striated soft tissue and gas material. This is the sock within the intestinal segment. But we notice that we can again see that nice line of the the duodenum and the pyloric antrum, no foreign material there. So even though this patient ate a cloth foreign object, it does not have a linear foreign body. So this could go to surgery for enterotomy and removal. We could also try medical management of this patient, maybe for 12 to 24 hours, and see if this passes. Fluid therapy, pain medications, and those kind of things. When we look at a case of a linear foreign body, it looks quite different. So here I have a lateral projection and a ventrodorsal projection as well, and we're noticing some of those features that I'm talking about. The first is that there's plication of the duodenum. So instead of that nice straight shot of gas extending down the duodenum like we had in the last case, we have this irregular margin, this undulating intestine that is plicated. It's stacked upon itself. As it peristalses along its length, it plicates down, and that's along that intestinal foreign body. So we've got this plication extending from the level of the pyloric antrum down the duodenum, and we also have these geometric gas opacities in a few regions, these atypical shapes, these angular margins of the gas opacities. We can still see that intestinal foreign body. It has a similar character to the one in the last case, where there is still cloth material here, but in this instance, this is a linear foreign body, and we know that because of the plication, the atypical gas opacities, and the presence of foreign material. So this is not one that we're going to recommend medical management. Now, if we look at this case, this highlights the importance of both the right and the left lateral projections. On the left-hand side of the screen, I've got the right lateral, and then on the right, this left lateral projection. And what I'm noticing is this foreign object within the pyloric antrum is anchored dorsally. So the duodenum leaves the pyloric antrum from a dorsal position and then courses caudally in the abdomen. And I see this anchor point of material here extending out into the duodenum. We can see that there's foreign material in this right lateral, but we don't get that nice example of the anchor. We don't get it surrounded by gas in this left lateral projection. So having both of these increases my confidence that there is a linear foreign body in this case. I'm also noticing that there is a stretch of plicated intestine with foreign material in it. And again, these atypical comma-shaped or unusual gas opacities within the intestinal tract. So looking again here, this is a zoom up of that left lateral projection. We've got this anchored foreign body in the pyloric antrum, which extends out into the duodenum. And this is that classic feature we want to look for in the left lateral projection. If we see this, this is almost always going to be a linear foreign body. And so we really need to carefully scrutinize for those other clues and hints that we should be looking for. So again, left lateral projection highlighting the foreign body anchor in the stomach, evidence of plication, evidence of atypical gas opacities like comma-shaped gas opacities, and medial displacement of the duodenum in that ventrodorsal projection. Those are the four things you're going to look for to confidently diagnose a linear foreign body every single time. I hope that helped, and if you're looking for more cases, hit subscribe.